Next, psychopharmacology. Psychopharmacology is the study and prescription of psychoactive medication to improve or support various aspects of mental function and to provide relief from mental dysfunctions, including emotional distress. Rightly or wrongly, the first patient contact with public health services is usually via emergency medical services or casualties. There, the greatest medical emphasis is on preserving life, identifying or excluding reversible biological and life-threatening problems, and then, if no urgent hospital admission is required for inpatient services, to refer to an outpatient service, including to mental health services. Sadly, outpatient health referrals from emergency departments, even in the case of suicide risk, is only 15% in adolescent populations and 30% successful in adult populations. As I said, for identified suicide risk patients with specific referrals. So even when these patients enter the medical system, it's not to say that they'll get to the right treatment. And also, given the non-specific, crisis-driven and almost clearinghouse-like function of emergency medical departments, it is unrealistic to expect comprehensive mental health services to be offered within that context. And so there's a great pressure to opt for psychopharmacology, and it's understandable that this might be a go-to decision. For many patients, it's either pills or nothing, and the chances of a patient being correctly diagnosed with a dissociative disorder in an emergency medical setting is unfortunately highly unlikely in the beginning. Equally tragic, however, is that the ongoing centuries-old controversy about dissociative disorders still presents barriers to successful diagnosis and treatment even when these patients are eventually seen in mental health services. Apart from the philosophical and clinical turf battle issues between, for instance, psychology and psychiatry, the capacity of the mental health systems in general simply isn't such that it can actually accommodate the prolonged psychotherapy these patients typically need. This becomes even longer when the diagnosis is missed. The bottom line is that all dissociative disorder patients are likely to take or be offered psychopharmaceuticals sooner or later. So then the question is, does it work and does it help? There are many ways to classify psychopharmacology, but from a practical perspective, they can be divided into pain medication, antidepressants, anti-anxiety, mood-stabilizing, antipsychotic, sleep, and attention deficit medication. The main challenge with dissociative disorders is actually knowing who and what you are treating. These individuals are not only polysymptomatic, but their symptoms vary widely according to the functional mental state they are in. So if they are depressed in one mental state, obsessive-compulsive in another, suicidal in another, and yet another has a substance abuse problem, then providing any medication that might help one might also complicate the others, such as increasing anxiety or posing an increased suicide hazard. In fact, it is common to find that medication that is usually effective in a specific condition is either unhelpful, highly variable in its effectiveness over time, or paradoxically aggravating of the condition or other comorbidities. This soon becomes a source of frustration and may result in the ultimate breakdown in the therapeutic relationship. It provokes a loss of confidence and hope in the client, and for the health practitioner, it raises suspicions of being either a fictitious disorder, hypochondriasis, or the result of non-compliance. All of these may be unfounded, but they are likely to be overlooked as dissociative disorder unless the neuropsychological features are understood in the context of dissociation. This is also where functional neuroimaging, particularly brain electrical activity mapping or QEEG, can be particularly valuable and restore an objective basis for intervention. This will be discussed in greater detail in the next section. The relative simplicity of prescribing medication, its relatively modest costs when compared to psychotherapy, and the impression we have as doctors that it may offer better day-to-day control makes psychopharmaceuticals a very attractive choice in any complex mental disorder. The reality, unfortunately, is far more sobering. In this article on the use of psychotherapy and pharmaceuticals for depersonalization derealization disorder, which, as you may recall, is part of the spectrum of dissociative disorders and a subset for which medication is likely to be considered early on, it turns out that it is unhelpful, in fact. This review states rather discouragingly that no efficacy has been established for medication, even for this more readily identifiable form of dissociative disorders. And when looking at the empirical overview paper we refer to regularly in the beginning when we considered the validity of the diagnosis itself, its comments on psychopharmaceuticals brings another contextual challenge to the fore. The article states, as neurobiological studies on DID accrue, they show that DID is as suitable for biological investigation as any other psychiatric disorder. But as DID shows only limited responsiveness to existing medication, it falls outside the purview of many researchers who focus on disorders that respond better to pharmacotherapy and short-term treatments, and those that are diagnosed by current standardized interviews. What this means, in rather blunt terms, is that DID is too messy and variable for psychopharmaceutical companies to risk the investment of research dollars on a controversial indication, which has a long and variable clinical course and is unlikely to improve the scientific credibility of the drug or the economic returns. In short, it is not worth researching from the manufacturer's economic perspective, which means that psychiatrists are left with making calculated guesses. And so essentially the existing literature on psychopharmaceuticals in dissociative disorders suggests that they are only of limited use, potentially hazardous in unanticipated ways, and may best be considered only for stabilization, but not for long-term symptom suppression or management. If anything, the failure of medication should actually raise suspicions of underlying dissociation. For any single medication to work long-term, the problem or condition would have to exist across all or most of the alters or alter personalities. So it's important to understand that limitation when medication seems to fail or be unpredictable. There's always the additional potential concern about suicide and dependence. But perhaps the greatest problem in dissociative disorders is that these difficulties in matching medication with the complaints distracts attention from the real issue, the underlying dissociative component. The comorbid symptoms like depression and substance abuse easily become the focus instead of the dissociation and the triggers for dissociation. In addition, we need to restate that people with dissociation don't call out or seek medical attention because they are dissociated. Dissociation is the maladaptation they have developed to find relief. When they do come, they come because they hear tormenting voices, feel depressed, or have somatoform body pain disorders. Once that becomes the primary diagnosis and the focus of treatment, the underlying dissociative diagnosis is missed. What is more, the other comorbidities remain hidden, unresolved, or resistant to treatment until the dissociative aspect is addressed. So this is very important to understand when it comes to medication and dissociative disorders. It has a place, but the information and recommendations must come from someone who is familiar with this condition, not just any health practitioner. Fortunately, there are an increasing number of mental health practitioners who have experience in treating dissociative disorders. Hypnotherapy. No presentation on dissociative disorders would be complete without also discussing the topic of hypnosis and hypnotherapy. Both are huge topics in and of themselves, and below is a reference that provides a more comprehensive review. For the purposes of this presentation, though, we will only discuss the most essential concepts, relevant research, clinical considerations, and treatment outcomes. To start with, some basic definitions need to be established. First of all, there is the so-called hypnotic state. This represents a heightened state of concentration or suggestibility, and it can be achieved in a variety of ways. Hypnotic susceptibility describes the relative suggestibility or hypnotizability of an individual or group of individuals, usually compared to a population average. Hypnotic suggestions are directions given to subjects whilst in a hypnotic state, and these may range from specific instructions to probing questions. Hypnotherapy is the use of a therapeutically induced hypnotic state for the purpose of relief, health promotion, or behavioral modification. Broadly speaking, there are two goals in clinical hypnosis or hypnotherapy. Firstly, directing or guiding a person's thoughts, feelings, or actions through varying levels of suggestion, and secondly, releasing information, memories, or emotions as part of a more interactive and analytical process. There are different styles of hypnotherapy during which either or both these goals may be achieved. Traditional hypnotherapy is the most directive version. The cognitive behavioral style, which has its origins in the desensitization of individuals to pain or anticipated pain, has now been expanded in combination with cognitive behavioral therapy towards promoting behavior modification. The most diverse or Ericksonian form is more conversational or reflective. Additional elements may be included in hypnotherapy, such as repressed memory retrieval, regression and so-called past life regression, and ego state therapy, including hypnotic abreaction. We will address these in greater detail shortly. There is some evidence in support of cognitive behavioral hypnotherapy in dissociative disorders. The objective, as described in this article, is to use hypnotherapy to contain, explore, process, and resolve life-endangering aspects of dissociation. It also details the cognitive hypnotic world of dissociative disorder patients, the relational aspects of the so-called ego states, and how hypnotherapy fits within the three-phase model of managing dissociative disorders in general. Abreaction is a psychoanalytical term for reliving a past experience with the objective of dissipating stored emotions, usually in relation to repressed traumatic events. The original concept was introduced by Sigmund Freud and Joseph Breuer. The concept has met with controversy from its inception, with Carl Jung being one of the first critics. Over the past centuries, it seems to have taken on many guises with a range of similar physical features. There is a certain amount of clinical overlap between manifestations encountered in so-called somatic experiences, trauma-releasing exercises, as well as hypnotically facilitated abreactions. And these are somewhat similar in some respects to those encountered in exorcism, deliverance, spirit depossession, as well as other spiritual manifestations like the Toronto blessing. Attribution of cause and therefore the validity and appropriate selection of treatment remain at the center of the controversies, though. Most recently, clinical hypnotic abreaction has become included in so-called ego state therapy, which overlaps with the practice of eye movement direction reprocessing, or EMDR. The main reason for this contextual framework for hypnotic abreaction is to ensure that there is first core identity stability before undertaking any emotional processing. Otherwise, unplanned abreaction may precipitate further instability and mental dysfunction. This is an overview article that discusses abreaction in detail, from its origins to its current practices. This article captures the essence of ego state therapy and also attempts to clarify the psychodynamic features and the differences between so-called inner self-helper and core identity states as encountered during hypnotherapy. And this article reports on the use of abreactive hypnosis in the context of ego state therapy in a PTSD population. The outcome of the abreactive hypnosis in this placebo-controlled investigation of 66 patients using different outcome scores indicated that only the hypnosis abreaction group gained and maintained significant clinical improvements. Now, these findings cannot be extrapolated to dissociative disorders without further research. However, these findings are likely to generate more willingness to pursue this type of therapy in the future. Electrophysiological measurements taken during hypnotic abreactions also support this as a true phenomenon. It also supports some of the original concepts of spatial temporal fragmentation as described by Pierre Janet, as well as many other recent neuroscientific findings in dissociative disorders. For hypnotherapy to be successful, though, individuals need to be hypnotically susceptible. In other words, the ease with which someone will enter a hypnotic state is likely to correspond to their responsiveness to hypnotherapy. With this in mind, various scales have been developed, of which the Stanford Hypnotic Susceptibility Scale and its derivative, the Harvard Group Scale of Hypnotic Susceptibility, are the best known and often used for reference purposes. For hypnotherapy to be successful, though, individuals need to be hypnotically susceptible. In other words, the ease with which someone will enter a hypnotic state is likely to correspond to their responsiveness to hypnotherapy. With this in mind, various scales have been developed, of which the Stanford Hypnotic Susceptibility Scale and its derivative, the Harvard Group Scale of Hypnotic Susceptibility, are the best known and often used for reference purposes. Potential links between hypnotizability and dissociative capacity are obviously part of the controversy surrounding the underlying nature of dissociative disorders and the credibility of traumatic memories of childhood. Recent evidence supports the link, and indeed, this could support the hypothesis that individuals who are more hypnotizable are also more likely to develop a dissociative disorder in response to traumatic life events in childhood. This does not, however, prove that traumatic memories are imaginary or hypnotically induced. The fact that there are, admittedly, cases involving fictitious memories does not negate the many ones that have been verified and the consistent global association between dissociative disorders and traumatic abuse as children. But it is possible for memories or recollections to be inaccurate, and it is also possible for hypnotherapists to create them inadvertently. Therefore, in summary regarding hypnotherapy and dissociative disorders, the literature cautions hypnotherapists against the pursuit of hypnotic abreactions in isolation, and to only offer it specifically if trained to manage the complications, not only to do the procedure. Secondly, not to suggest or insist on the presence of traumatic memories. Thirdly, to suspend premature belief and also disbelief in the accuracy of memories retrieved during hypnotherapy. And fourthly, to avoid a fixation on trauma memory and emotional release to the exclusion of fostering stability, coping, and other interpersonal skills. Most importantly, however, the safety of these vulnerable individuals must be assured, both inside and outside the hypnotherapy office. As such, the recollections of past events and the descriptions of current hazardous life circumstances should never be disregarded.